so obviously I love to eat too. So. All right, so we're going to talk today about diverticulosis, diverticulitis, and colon polyps. Again, pretty easy stuff. We'll just kind of a anatomy review. The colon and the rectum are considered part of the large intestine. About 6 feet in length, kind of an upside down U. Starts at the cecum, which is kind of this pouch, the beginning of the large bowel. The ascending colon on the patient's right side, hepatic flexure, transverse colon up top, descending colon on the left side of the abdomen, and then that kind of S-shaped sigmoid colon, and then the rectum. I think we pretty much talked about all that. Yeah, you have the hepatic flexure and the splenic flexure, where that you kind of. All right. There's several layers in the wall of the colon. Most internal, facing the lumen of the colon, is the mucosa, submucosa, then the muscular layer, and then you have the serosa, which is on the outer part, out towards the peritoneum. There's just another figure. That's kind of small, isn't it? My eyes are, I'm getting old. Okay, so a diverticulum, singular, is kind of this outpouching sac, a herniation, so to speak. It develops in an area of weakness of that colonic wall. The mucosa and submucosa goes through that muscular layer, and so you basically just have the serosa that's covering that area. So it's thinner than normal. Excuse me. Diverticular disease is when a person has one or more diverticuli, but it's implied that they're without symptoms. Okay, so that's diverticular disease. Although you can have symptomatic diverticular disease and asymptomatic diverticular disease. Diverticulosis, you know, having diverticuli is an acquired thing. We're not born with these things, and it's much more common as we get older. Quite uncommon below the age of 40. By age 60, about 50% of the population, this is in the U.S., and then by age 80, 70% of the population. It's very strongly associated with a Western diet, low fiber diet. You find in other countries where they have high fiber intake, you essentially don't see diverticulosis. So it's been around for a while, described as early as 1700. Prevalence is pretty much similar, however, males tend to present, you see them presenting earlier. In the U.S., in Western civilization, it predominates in the left side of the colon, especially that sigmoid colon. Oddly enough, some of the Asian countries, it tends to be more right-sided. I have no idea why that is, but that's the case. So you might just keep that in mind if you see someone of Asian descent, and have to remember that that could be backwards. Okay, so why do we get these little herniations? It's multifactorial. One of the big things is colonic pressure, intraluminal increased pressure. And there's something called segmentation where, usually peristalsis is kind of a coordinated contraction of the longitudinal muscles. Then we have these circular muscles that are kind of in bands along the large colon, and these will contract. And by contracting the circular muscles, it helps kind of turn the stuff in there so that you get better absorption. But this segmentation causes a localized area of increased pressure between those two circular muscles. And it's thought that this encourages that herniation. Plus, it tends to do it in areas of weakness. The area of weakness that they have found is where these blood vessels penetrate through that muscular layer, and that's the vasa recta. So that just is going to go to area of least resistance, and that's where it is, and that's generally where the herniations occur. They also found that people who have diverticulosis tend to have this muscular thickening, which is called meiosis, and it's thought to be they get increased deposition of collagen and elastin within that muscle. It's not necessarily the entire wall, but it's the muscle component within the wall of the colon. And this obviously leads to decreased resistance. It's not as pliable, so to speak. Okay, you also have changes just as we get older. We have potential changes to our colon. One thing is that the collagen and muscle fibers tend to become a little weaker, and so that makes them more prone to that distensibility. Good morning. Which again encourages that over stretching, so to speak. And it's also thought that there is just a chronic low-grade inflammation associated with diverticulosis and itis as well. Mainly to the area where you see the diverticuli. Dietary fiber, that is a big one. It's actually deficiency of dietary fiber in our diet. Dietary fiber is protective in a couple of different ways. It helps to bulk the stool so that our colon doesn't have to clamp down quite as hard to push it through. So in that way it's beneficial. Also certain types of fiber actually provide some very good nutrients to the mucosa, the inner lining of the colon. So in that case it just increases the integrity of the colon wall. Alright, so when we're fiber deficient, obviously we have more increased pressure because the muscles are having to contract more, and therefore you're at greater risk of getting that herniation. And here you can see the actual herniation. Okay, so diverticulosis is having one or more diverticuli, okay? The large majority of people with diverticulosis are asymptomatic, 80–85% of people. Usually it's an incidental finding. Say you're getting your routine colonoscopy for screening of cancer and you're just found to have diverticuli in there. We also have symptomatic diverticular disease or symptomatic diverticulosis. This is when a person has kind of intermittent, usually, again, I'm going to be talking about the left lower quadrant since we're in the United States, but always know there could be a little bit of a variation depending upon the population that you're seeing. But predominantly attacks of this left lower quadrant pain without evidence of inflammation. So no fever, no spike in the white blood cell count, things like that. No tachycardia, fever, things that would make you think an inflammatory process or infectious process is going on. So the pain tends to be colicky. You understand what colic is? Where it kind of builds up, builds up, builds up, and then calms down. Kind of like you get when you're having, you know, that crampy diarrhea or whatever. It's just miserable. That's often relieved after they do have a bowel movement or pass gas, and eating can oftentimes, you'll see this get worse after eating. Can have a number of other symptoms: bloating, nausea, irregular bowel movements, constipation more than diarrhea, but you can have either, almost like a irritable bowel sort of a sounding, and bleeding. Sometimes bleeding can be the first and only symptom that you have, and it can be sometimes quite significant. We'll talk about that down later on. On exam, you may notice a little, when you're examining, you may notice a little fullness or tenderness to that left lower quadrant. It might have some, you know, mild voluntary guarding. You know, it's not going to be rigid and like that, but the person may voluntarily guard a little bit. Okay, how do we find these diverticuli? Imaging. Barium Enema will demonstrate these, but they're not. It's not good at ruling out other things that could be in the differential. All right, so colonoscopy is much better at finding these other conditions that are on your differential. So that's probably the better way to go. You do want to know that if you are suspicious of a person who is in acute diverticulitis, which we will talk about here in a second, it's relatively contraindicated because you could encourage perforation of the bowel, which is not good. It tends to be life-threatening. So in that scenario, you would not want to maybe consider colonoscopy. All right, so here is a barium enema. You can see the little polyp sticking out there. And then kind of the opposite view when you're looking from the inside out, you can see again the outpouchings on a colonoscopy. That's a clean bowel, isn't it? And I'm like, I'm over 50, so I have to go do my, I'm the world's worst patient. I'm one of those that just sticks my head in the sand, and it's like, okay, I'll find out when I'm half dead. I know that's horrible, but that's okay.
We need you.
Do what?
We need you.
You're so sweet. I will do it, I promise. Once I get my parents, you know, under better control, and I get my daughter graduated, I will go do my colonoscopy. I may not put the pictures up on the wall like Dr. McNeil does. I can't say I'm that dedicated, but. All right, so what's on the differential? There are a bunch of different things that can, you would consider in your differential. I'll let you read through those. We don't need to read through that. Okay, so treatment for diverticulosis. No inflammation, just having the more of the symptomatic, or really, you want to encourage some of this, at least the dietary changes, even if you find it asymptomatically, or you find it and they're asymptomatic, because it can decrease the risk of them becoming symptomatic. All right, so fiber-rich diet, that's key. Some other things probably, they're a lot more symptomatic, would be non-absorbable antibiotics, mesalazine, probiotics, and prebiotics. We'll talk about those here in a little bit. I always learned, I don't know if it was in dietetic school or in PA school, but it was like, they cannot have nuts or seeds or popcorn or anything like that, because it's going to get stuck in there, and that's what's going to cause diverticulitis. Did you learn that that's just completely opposite?
Yeah, in school we learned that they couldn't eat this.
Oh, you did too?
But then afterward I was kind of reading some research about how it's not.
Yeah. that was kind of news to me. I learned something from way back when. So you don't actually, that fiber may be beneficial. So, so you don't have to tell them no nuts for you. Nuts for you. You guys are probably too young for Seinfeld, the soup Nazi. You've seen that? Pretty funny. Okay, so fiber. Fiber, we've talked about that. It shortens that transit time, how long the stool is in the fiber, and helps to reduce that colonic pressure. Recommended daily intake is 20 to 35 grams a day. High fiber foods are your fresh fruits and vegetables, your whole grain cereals and breads and beans. Those are all very high fiber products. Or there's over-the-counter supplements, fiber supplements. They have soluble fiber and insoluble fiber, both of which are beneficial for this in two different ways. And then I gave you some examples. Anything else you want to, from a dietetics standpoint? Very good. Okay, non-absorbable antibiotics. The name of this is rifaximin, broad spectrum antibiotic. They don't really know how this helps, but about 90% remains in the gut. And it's thought that it kind of helps with that low-grade inflammation that's potentially going on, that chronic low-grade inflammation, and that it somehow kind of helps with the gut flora so that they break down that dietary fiber. We don't really know. These are just kind of speculations, but that if you have a person that has symptomatic diverticulosis, this is something you might consider short period of. I'm not gonna ask real deep questions over medical treatment. Is Dr. Latassi doing anything over this? No? Okay. You might just be aware of the names of these, but I'm not gonna ask dosing or anything like that. Definitely fiber stuff. You need to know that that's pretty key. Mesalazine, I see that you guys talked about that here. This is typically used in inflammatory bowel disease, but it's something that you might consider for symptomatic diverticulosis as well. Again, it's just thought to, it's kind of an anti-inflammatory medication, so thought to help with that chronic low-grade inflammation. Probiotics and prebiotics. Probiotics help to reestablish the normal bacterial flora within the gut. The two bacteria, lactobacilli, and this other one I'm not going to try, bifidobacteria, did I say that right? Bifido, excuse me. Bifidobacteria. Those are the main two that we try to replenish. It's thought that by, from what I understand, when there's a decreased transit time, the stool stays in the gut longer, we tend to lose some of the good bacteria, so this helps to replenish that, and by doing that can help with the symptoms. Prebiotics kind of help promote the growth of these two same bacteria. They're usually complex carbohydrates that are indigestible. There's examples of them down on the very bottom. And it's thought that these cause the bacteria in the bowel will kind of ferment these, and this kind of changes the pH in there and allows the growth of the good bacteria and a decrease of the harmful bacteria. Okay, let's switch gears a little bit to acute diverticulitis. So, itis, the suffix implies inflammation and infection, and that's exactly what happens. You actually get micro, little small perforations within the diverticuli. And sometimes you can get some kind of congealed food substances stuck in there, which will cause inflammation. And you have, increased pressure that stretches on the diverticuli and encourages the micro rupture or larger. Okay, so age, as male predominance, younger than 45, between 45 and 54, it's kind of equal. Older than 54, you tend to see more females with diverticulitis. There is a classification, this Hinchy classification. You don't need to know it, I just wanted you to know that there is a classification system. Okay, so again, what causes this? Again, that increased pressure within the gut. You already have just you have a thinner than normal mucosa. Just the serosa covers this, and then the blood vessel. So it's already thinner than normal. You get inflammation associated with that, and it just kind of is at greater risk of having microperforations or larger perforations. Again, we talked about that change in the bacterial flora. Again, the soluble fiber is better. We talked about because when we have that in the bowel, the bacteria within the bowel ferment that, and that again supplies these short chain fatty acids that are the best nutrient source for the cells on the mucosa of the lining, the colonocytes, excuse me. And that again increases that integrity of that barrier. All right, one important thing too is non-steroidal anti-inflammatory drugs. These medications are associated with diverticulitis, acute diverticulitis, as well as perforation, larger perforations. It's thought, one, it's kind of a weak acid, so it just topically can irritate and cause some damage to the lining of the mucosa. But it also decreases prostaglandins, and prostaglandin is helpful to maintain that barrier within the mucosa of the colon. So a combination of those two, and it can encourage perforation. Again, dietary fiber. We've heard that 18,000 times already. I don't even know. Oh, one thing, red meat in particular is associated with diverticulitis. I guess as we break the meat down, we get heterocyclic amines, and these are known to kind of break down the epithelial cells. So you may want to encourage not only increased fiber, but not, what should I say, try to diminish how much red meat a person eats throughout the week. All right, so after we get this little micro perforation, the body tries to keep it localized. And that's typically what happens with just your general diverticulitis, is you have more localized inflammation, infection. If it's a larger perforation, the body can't keep that reined in, and so you tend to have a wider spread peritonitis or an abscess formation, some of these complications. If you have this chronic septic process, inflammation, infection, it can actually erode into an adjacent organ, and we'll talk about this. That's called a fistula, when there's an abnormal communication, in this case between the colon and it can be the skin, the bladder, or the vagina. And so that's fistula formation. We'll talk about that. All right, so the big things, symptoms that a patient is going to present with is abdominal pain, lower, usually left-sided, left lower quadrant pain, fever, and elevated white count with diverticulitis. Not diverticulosis, but diverticulitis. Biggest complaint is that left lower quadrant pain. It tends to be constant, but with exacerbations. You can have other symptoms, nausea, vomiting, diarrhea, constipation, even some urinary symptoms. Because if you think about it, if you've got an inflamed sigmoid colon, which sits right next to the bladder, you can get some increased frequency of urination and feeling like you gotta go right now, urgency. All right, on exam, you are going to find tenderness to that left lower quadrant, and sometimes you can even feel a mass. Guarding, the patient will show some guarding and rebound tenderness to that area. If it's widespread, more widespread peritonitis, then you got to be thinking about possible larger perforation or abscess usually is more localized, but okay. If you've got a real distended abdomen and no to little or decreased, I just was thinking breast sounds, and that's bowel sounds. Let's try the bowel we're working with. Oh yeah, I'm out of pulmonology, aren't I? Get with it. So if you have that scenario, an ileus could be present, or a bowel obstruction. Ileus is kind of, have you talked about ileus? It's basically where, it's almost like it's paralyzed for a little bit. It's in shock, the bowel, and it won't do that normal peristalsis. It just is sitting there. Or a true obstruction when you have scar tissue and things like that. Okay. When you have a large perforation, a larger perforation, you're going to have a very sick person and a very rigid, distended abdomen. Okay, leukocytosis, elevated white count, is the most common on lab findings. Pretty much everything else is normal. If you have a really high white count, you need to think about some of the complications, such as an abscess or perforation with widespread peritonitis. If you have elevated amylase levels, you again need to think about perforation and peritonitis. Normally, under just a normal diverticulitis without a complication, they're going to be normal or just barely elevated. Okay, so how do we evaluate for this? Your CT scan is the number one thing you're going to do. Again, it's the best in determining whether there's these complications that can occur with diverticulitis. And, you know, if you have a person, this is a very important comment too. Since the CT scans cannot reliably exclude cancer, patients who have not had a recent colonoscopy should have one 6 to 8 weeks after their diverticulitis is resolved. I think that's important, because when so much inflammation and such is, well, first of all, you're probably not going to do a colonoscopy when they have acute diverticulitis, but you need to make sure that there wasn't a cancer or something like that that was causing some of these symptoms. Barium enema, we don't really use this with acute diverticulitis because you're at risk of getting that barium material into the peritoneum if there's a perforation that you don't know about. And again, it's relatively contraindicated for a colonoscopy or some of those other scopes, because you're at greater risk of perf. You have to add air. I heard that story that Dr. McNeil, oh my God, I had not laughed that hard. Oh, I wish I could have been a fly on the wall. Were you back there for that?
I heard the story.
It's on YouTube.
Do it.
I would want to be a fly on the wall, but not on that.
No, yeah, on the opposite side. Very good point. Very good. Yeah, I don't want a face full of fecal material. Oh my gosh, I just wish I could have seen that. So funny. Okay, so treatment of acute diverticulitis. Uncomplicated without some of these other secondary complications, and they're clinically stable and they're able to tolerate fluids without vomiting. You can treat them outpatient. You basically just want to have them rest their bowel, just do a clear liquid diet only, and get them on some antibiotics. Antibiotics, you want to cover two main things, your gram-negative rods and your anaerobes. And there are some suggestions. I might at least be a little familiar with some of these outpatient drug combinations that you may want to use, consider. They stay on the clear liquid diet for a couple of days. They should start showing some improvement within 2 to 3 days. And as they improve, then they can advance their diet to, more solid food. If a person is not getting better after 2 to 3 days on antibiotics, their pain is getting worse, their fever is not coming down or getting higher, you need to hospitalize them, and more than likely they've got a complication going on that needs more aggressive treatment. All right, inpatient, you're going to, if they're sicker, more severe presentation, your older patients, if they're not able to keep anything down, or they have other, diabetes or other comorbid illnesses, then you would consider getting them in the hospital from the get-go. Again, bowel rest. With them, you're going to give them IV fluids and IV antibiotics, and there are some suggestions, but again, I'm not going to, you certainly don't need the dosing and that sort of thing at this point. Okay, what are some of the complications? All of these more than likely will require surgical consultation. So you'll be calling a surgeon and saying, hey, I've got this person, I think you need to evaluate them. Abscess, okay, again, we talked about, typically our body tries to contain that inflammation. If it's not able to, it can spread and it can cause an abscess. You tend to think about this if a person has a really high fever, or a really high white count, or if you've treated them with appropriate antibiotics and they're just not getting better. All right. A fistula, again, these abscesses can progress to a fistula where you get this opening communication between, in this case, the colon and other surrounding organs or structures. The bladder is the most common, especially in men. Us women have a uterus, so that kind of helps, most of us anyway, have, that kind of helps, it's a normal blockage, or so that the bowel is not able to communicate as well with our bladder. If you notice that a person is passing stool through the skin or into the vagina, or air or stool through the urinary tract, then that obviously is an indication that there is a fistula. Intestinal obstruction, again, when you have just kind of either chronic or intermittently chronic inflammation, infection, this encourages fibrosis or scar tissue to form in there, and that can then entrap the bowel and narrow that lumen significantly or completely. with this, you're gonna get, so then you get air, nothing passes through, so you get, the patient's gonna, you know, not be able to put anything in their mouth, they're gonna vomit it up, and they're gonna get very distended, because you get the air just build up, it's not able to pass through, they're not passing gas and things like that, so. Most of these will kind of, you rest the bowel, you probably put an NG tube to suction out the stuff in the stomach and give them some IV fluids, and usually the body will kind of take care of it on its own. If it doesn't though, then they probably need to go in for surgery. A larger perforation with peritonitis, but this really, I mean, you think about that, you've got what's normally entrapped in that colon or the bowel, and now it's out in your peritoneum, and that is not good. Increases your mortality rate to as high as 35%. I got a little funny story you'll appreciate. When I worked as a dietitian, I was down in Dallas at Parkland Memorial, so you saw all kinds of characters there. And I worked mainly with IV nutrition or tube feedings, and so I was in the trauma intensive care unit, and there was this one gentleman who came in, he had, I don't know why he did this, but he put a zucchini up his behind. And it got like sucked up there. He went after it with a hanger. Note to self, don't do that. And he perfed his bowel, and he died. He ended up in improvement. Yeah. So remember that. Note to self. First of all, stay away from zucchini. And second, don't retrieve what they crazy stuff. I'm sure you have all kinds of stories, interesting stories.
She's got good stories.
I'm sure. You what?
I said, someday when y'all are graduates.
See, I care with it now. All right, so with an intestinal obstruction, you're going to have a severe abdominal distension we talked about. Nausea, they're not going to be able to keep anything down because nothing's moving through. Usually, we already talked about that, may require surgical intervention. Perforation, oh that's right, we were on perforation, that would have got me into the, into the zucchini story. Okay, so when a person has a larger perforation and peritonitis, that diffuse peritonitis, that's their belly is going to be, those muscles are going to be contracted, they're going to be involuntary guarding, you know, versus, oh, don't, you know, that hurts a little bit. Involuntary is where you start touching the belly and it just spasms up, and decreased or potentially absent bowel sounds. Again, important to know, this is linked with non-steroidal anti-inflammatory use. Possibly steroid use as well, but there's not as much conclusive evidence. Okay, are we ready to just plug on? I don't have much longer to go. Okay. So diverticular hemorrhage, this is a potential complication. It's the most common cause of the major lower GI bleed. Yet only a small percentage of people with diverticulosis actually have this. It is an arterial bleed. Again, we talked about how you have your diverticulum, and that artery is right along that outer edge of it, so it's just out there to become compromised, so to speak. So it's an arterial, it can be a massive bleed in about a third of the patients. It oftentimes, rectal or GI bleeding can be the first and only sign that a person has. You know, and it can be anywhere from a little spotting every now and then to, again, a massive bleed. People at risk are people with hypertension, atherosclerosis, And again, aspirin, because you tend to bleed on aspirin, and then that non-steroidal anti-inflammatory use. For a bleed, your better choices are a colonoscopy or an angiography, because both of those you can do some therapeutic maneuvers. With the colonoscopy, I think they can cauterize in there. With the angiography, they can infuse vasopressin, a vasoconstrictor. The nuclear bleeding scan is something that you can do, but it's for diagnosis only. You can't do any therapeutic techniques. So again, large percentage of people, these GI bleeds or the bleeding from the diverticulosis or diverticuli will stop spontaneously, but again, when it's not, it needs surgical intervention. You know what, I'm missing. Oops, hang on. Okay, so colon polyps. So colon polyps are kind of considered a precursor. The majority of colorectal cancers are believed to arise from these benign adenomatous polyps. You can have symptomatic or asymptomatic. Sometimes they'll bleed a little bit too. They can range in size from very small to several centimeters in diameter. The thing about this, the good thing about this, is that they convert into cancer over a very slow period of time. It's usually 10 plus years, or plus or minus 10 years. So that's a good thing. So you can routinely screen these people, take them out when you see them, and save their lives. So by removing them, decreases that risk for lethal colorectal cancer significantly. Certain characteristics place a person into higher risk, and that is if when they're doing their first colonoscopy, they see 3 or more of these polyps in there. If they are larger, greater than a centimeter in size, or if under the microscope they have these certain features, high-grade dysplasia or this villous appearance. These people, they're going to recommend a colonoscopy in 3 years versus 10 years, I think, which is she better knows the screening recommendations. But this one you need to follow them more routinely. All right, so there's also a condition called familial adenomatous polyposis, FAP, and this is when they're found to have hundreds to thousands of these adenomatous polyps, these polyps within the colon. And a person has nearly 100% of developing colon cancer by their middle ages. If they don't keep up with these polyps, or typically what they need to do is just take out that small segment of the colon and just remove it. So there's only a small percentage of cancers from this cause, but it's something you need to be aware of and make sure we monitor. It's an autosomal dominant hereditary inheritance, but about 30% of the time it can just have a gene mutation and presents de novo. All right, so usually by the second or third decade of their life, they already have polyps in there. There are also people who have this condition are also at greater risk of other cancers away from the colon, such as the thyroid, the adrenals, and central nervous system. Okay, and that's just to know that, and then you would want to do screening for that area as well, those areas as well. For these people, screening should occur by the age of 11. So we need to get on these people, otherwise they will die in their 30s potentially. And there is genetic testing available for this. And I think that's it. Heck, we could have slept in longer. I just wasn't sure. I knew I didn't need the whole 2 hours, but any questions?